Good evening, everyone, and welcome to the Marudhara Hematology Update. It gives me great pleasure to invite our program chairperson, Dr. Hemant Malhotra, to give the introduction and welcome. Over to you, sir.
Thank you very much, and welcome to all the faculty and the delegates who are watching this hematology update. We have speakers from all of Marudhara. Marudhara, you know, is the Maru area of the country, which includes several parts of Rajasthan and Gujarat. So, like we will, with faculty from these two states and an audience from all across the country, we will look at some of the recent advances in hematology, particularly malignant hematology. And I'm thankful to Mr. Sipla for organizing this and for getting us together. All of you would be aware that huge advances are taking place in hematology and medical oncology, and we need regular CMEs like these to keep up to date and to offer the best possible treatment and the best possible outcome to our patients with blood cancers. Also thankful to Kavina Creations for doing the back office work and organizing this meeting. We will cover several aspects of lymphomas today, and then we will move on to acute leukemias. We have several speakers. Each will be given 5 to 10 minutes and to focus on one specific topic. We will talk about the role of imaging in lymphomas, some new drugs, results of some ongoing and some recently concluded trials. And then we will finally have Dr. Lalit Mohan Sharma conclude the evening's proceedings. Dr. Lalit Mohan Sharma will also, set the context for this CME. And I think it is time now for me to invite Dr. Lalit Mohan Sharma, who will introduce the various aspects of this CME to you and then launch the CME. Over to Dr. Lalit.
Thank you. Thank you so much, sir, for your kind introductory words. And we all agree that the hematological aspects are being discussed, in fact, on a very, very regular basis at various national, international platforms. And we were also keen that we discuss the hematological malignancies, especially in different platforms. And we try to focus on the updates, and we felt that we will take only 2 topics at a time. So today we will be discussing about the lymphomas, and then we will discuss about the leukemias. So we will have 6 abstracts, top practice-changing studies. In fact, 6 we will take, and then after those 6 presentations, one presenter will be presenting 2 studies, 5 minutes each. And then at the end of that, we will have a panel discussion, and the speakers will also be part of that panel discussion. And a few other learned faculty experts, senior faculty will be there in the panel discussion. And then we will move on like this. So we felt that this is part 1, and we start with the leukemia and lymphoma discussions today. So I'm thankful to Professor Hemant Malhotra, sir, thankful to the CIPLA team, Devendraji, for taking this forward. Thankful to Dr. Devang, and thankful to all my learned faculty, Dr. Deepak, Dr. Ajay Yadav, Dr. Vishnu Sharma, Dr. Upendra Sharma, and we all will introduce to each other, in fact, in subsequent time. The first session will be started.
Thank you so
much. So
you
got the slides for the first session.
Thank you so much, sir. Moving on to our first session, what's new in lymphoma?
So,
I would like to the first speaker, Dr. Ashish Verma. Over to you, sir.
Thank you, organizing committee, especially Hemant sir, Lalit sir, for giving me this opportunity. So we are starting with our first session.
Dr. Ashish is a good friend of ours and currently working at Apex Hospital in India.
Ji sir. Thank you, sir. So we are starting with our first session, what news in lymphoma, and the topic for this first session is the prospective study This is evaluating the role of MRD and CT imaging surveillance following the first-line treatment in the patient of DLBCL. So, this is a brief background slide about the relevance or significance of MRD surveillance. Complete remission is very common in DLBCL following the first line of therapy. However, relapses can occur in 40 to 60% of cases.
Sorry to interrupt, sir. So your slides are not visible.
Not visible, huh?
So you will have to share your screen.
So, screen.
So if you can come on the Zoom, so at the center bottom, you can click on share screen.
So it's okay. It's visible.
Perfect, sir. So if you could make it into present mode.
Okay. Now, okay.
So I would request, sir, with your permission, I may just stop your screen share. So if you can share your screens after clicking on share screen, if you can click on screen.
Share screen. Screen. Okay.
Yes.
Share.
Sir, yes, sir.
Yeah. It's now okay.
Perfect, sir.
Yeah. So we start with from start. So we are starting with our first topic. There is a prospective study evaluating the role of MRD and CT imaging surveillance following the first line of treatment in patient with DLBCL. So my slides are not moving. My slides are not moving. What to do? Manshi?
Sir, if you can try using your arrow keys. So with your permission, we have shared your slides. So if you can just say next whenever you want us to go to the next slide.
Yeah. Okay, thanks. So yeah. So with a brief background about the MRD surveillance in patient of DLBCL. So complete remission is common in DLBCL following the first line of therapy, that is commonly R-CHP based chemotherapy. However, relapses can occur in 40 to 60% of cases. Early detection of relapse may be associated with improved outcomes. The utility of post-therapy CT surveillance in order to detect early, which having the studies regarding the CT surveillance follow-up in post-therapy patients have done previously, but it show various drawbacks and lack of clear survival benefit. So retrospectively, data analysis was done previously also, and they suggested that MRD monitoring, that is a measurable residual disease, during the DLBCL surveillance post-treatment could identify the patient at risk of recurrence before the clinical evidence of disease. So this current study basically prospectively evaluate the role of MRD, so the molecular technology, that is NGS-based technology, for the early detection of molecular relapse in patient with DLBCL. So next slide. So this is a study design. It's a prospective multi-center study in which we enroll around 500 patients, which was newly diagnosed DLBCL or some high-grade lymphoma, that is a double-hit lymphoma, T-cell rich B-cell lymphomas, receiving one line of multi-agent chemotherapy, whether it is R-CHP-based chemotherapy or salvage chemo followed by the autologous transplant. Basically, we exclude the patient which was transformed from the low-grade lymphoma, that is the Richter transformation, and we have done the baseline sampling in order to detect the clonotype of the lymphoma. That is the marker for the MRD evaluation, whether it is gene rearrangement in the form of heavy chain variable gene rearrangement, immunoglobulin kappa gene rearrangement, or some translocation with heavy chain in with the BCL1 or BCL2. These are the clonotype we have done at the baseline before the start of the treatment, and the primary endpoint of this this assay is to assess the diagnostic accuracy of the test, that is in terms of sensitivity, specificity, negative predictive value, and the projective predictive value, and the sampling was done before the start of treatment, during the treatment, and within 3 months of the completion of the treatment, that is the MRD blood sampling. And after the completion of treatment, we have done the response assessment in the form of PET-CT. The patient who attained the CR was followed periodically for next 2 years with 3 monthly sampling for the MRD assay and 6 monthly for the imaging point of view to detect the radiologically of disease relapse. And the positive MRD was defined as any detectable rearrangement in terms of whether it is BCL2 heavy chain rearrangement or IGH variable region gene rearrangement. Any time during this follow-up was termed as MRD positive. So next slide. So this is the response of this treatment in patient of DLBCL. We have followed almost for 3 years, around 34 months. And at the end of 2 years, 90% of the patient was in remission. However, 43 patients were relapsed, and the relapse were clinically in terms of 4 patients, radiologically in terms of 19 patients, and with a combined modality means clinically as well as radiologically is almost around 20 patients. So next slide. So if we assess the MRD in the relapsed patients, means the patient who are relapsed, that is among 43 patients, we are unable to assess MRD in 5 patients because of various technical issues. Might be the samples failed quality control criteria, calibration criteria, or they have not regularly followed for the MRD assay evaluation. So we have evaluated in 38 patients for the MRD results, and in 38 patients, 19 patients were so MRD positive who were clinically relapsed, and the median time for this MRD positivity is around 3 months. However, 14 patients were MRD negative. This is a surprising data, and this will question mark the role of MRD in the evaluation or the surveillance of post-treatment DLBCL. That is, even though the patient was clinically relapsed, they have a B symptoms, they have a palpable lymph nodes, but the MRD value is undetectable, means negative. Next slide. So if we evaluate the role of MRD in patients who were in CR, so again, among 356 patients, we are able to evaluate in only 279 patients. Other patients will, like in last slides, have failed the QC criteria or having failed the calibration criteria, or still the results were pending at the time of evaluation of this test. So we are able to evaluate in 279 patients, almost 78% of patients, and in 218 patients, 78% of patients were so MRD negative who are in CR. It's okay, but in 22% of patients were MRD positive, even though patient was in CR. The MRD evaluation was done either through the plasma sample or through the mononuclear cell. So next slide. So if we assess the diagnostic accuracy of the test of the MRD assay, the plasma sample is more accurately predict the sensitivity, specificity, and the predictive value, whether it is positive or negative. So we can say that the MRD assessment can be done through the plasma value from the plasma sample, but still the diagnostic accuracy test was not that too high. The sensitivity is almost around 68%. It is very low sensitivity. Next slide. So we can conclude this trial of MRD surveillance that even though previously the CT imaging was not that too relevant to follow the patient, but in this trial, almost 44% of patients were detected radiologically, even though patient was in asymptomatic phase, and this will support for the early detection of the disease, even specifically in the patient who are in advanced stage or having a CNS IPI of high risk. So if we detect patient in early stage, the treatment outcome of the salvage chemo, whether to go with conditioning with autologous transplant, is success of treatment is more. However, if we see the MRD assay, the sensitivity of this assay is suboptimal. Might be due to the reason like if patient attending the PET scan, means the PET CT is negative, having a DLBCL score of 2 to 3, that is patient was in complete remission. The sample that is we have to assess the MRD is DNA only. So the tumor DNA were not able to detect in that sample who attend the PET negative CR. or might be that tumor DNA is deranged during the collection or during the sampling process. And yes, the plasma MRD detection was more sensitive and specific as compared to the mononucleoside MRD detection. So still, this assay needs more evaluation, and we can see each and every molecular test have its own logistic, scientific, and technical aspects, and the cost is also.
Dr. Ashish, may I request that all this we will be discussing in the panel. Yes. Since the slides are by somebody else, so we just present the major points, and we will discuss in the panel discussion. Yes. Please, thank you.
So yeah, thank you. So yeah, we can proceed with our second topic.
Yes.
Yeah, can we share the slides? Yeah, thanks. Yeah. So it's a POLARIX trial. Basically, it's a revolutionary trial in the treatment of DLBCL. So with the background of DLBCL treatment, R-CHP was the standard frontline treatment. With the availability of Polatuzumab, that is the targeting against the CD79B antigen, it is basically expressed on the mature B-cell lymphoma. It's a monoclonal antibody conjugate with cytotoxic drug, that is monomethyl auristatin. It's the inhibitor of microtubules. So in this trial, actually they basically compare the efficacy and safety of Polatuzumab with R-CHP versus R-CHP in de novo or untreated DLBCL patients. Next slide. So this is a study design. Is a multi-center, double-blind, placebo-controlled phase 3 trial. Almost around 879 patients was enrolled with the age group of 18 to 80 years, who were previously untreated, with the IPI from low, intermediate to high risk, and the performance status of from 0 to 2. At least they can do their self-care. They basically divide the population equally in two arms. In one arm, they will give Polatuzumab with R-CHP, and in the second arm, they will give the standard R-CHP treatment. After 6 cycles, they will give 2 more cycles of Rituximab, and periodically they will assess the primary endpoint of progression-free survival and the secondary endpoint of event-free survival, complete remission, disease-free survival, overall survival, and the safety. Next slide. So this is the baseline characteristic of the populations. Almost in both the arms it is similar, whether it is age group wise. The median age group is 60 to 65 years of age. The bulk disease, that is a more than 7.5 centimeter, almost similar in both the treatment group. The stage by also basically the percentage of stage 3 and stage 4 is more as compared to stage 1 and stage 2 in both the arms. And basically the more patients are of high IPI from 3 to 5, and both the high risk group, that is whether it is double expressor or double hit or triple hit lymphoma, the percentage of patients are almost similar in the two arm of the treatment. So next slide. So if we see the result analysis of this trial, the attainment of complete remission in both arms is around 86% in Polatuzumab arm and 82% in the R-CHP arm, and partial remission is almost similar in both the arms, 9.3% and 11.4%. Next slide. So this is the analysis of primary endpoint. It is a progression-free survival. If we see the Polatuzumab arm, that is a blue graph, the blue graphical representation, it is significantly high with the P ratio is less than 0.05. So yes, Polatuzumab along with R-CHP significantly increase the progression-free survival as well as the event-free survival. That is the secondary endpoint of this trial. Event-free survival means patient in the R-CHP arm may need a second line of treatment. Might be patient needs salvage, whether it is patient may need a radiotherapy treatment. Whereas in Polatuzumab arm, the event is not that too high, and the patient having a significantly high event-free survival in the Polatuzumab arm. Next slide. So if we see the disease-free survival, that is also the secondary endpoint. Disease-free survival means if patient attain the CR in both the arms, whether it is Polatuzumab arm or the R-CHP arm, the attainment of CR is more in the Polatuzumab arm when we follow up the patients, but it is not significantly different from the R-CHP arm. But percentage-wise, if we follow the patient periodically, the attainment of CR during the follow-up is more as compared to the R-CHP arm. And if we see the overall survival is almost similar, but the bias here is that the follow-up is almost 2 to 3 years. If we follow at least for 4 to 5 years, might be it will come different. So yeah, as if now the overall survival is both the arm is similar, but significantly high in terms of progression-free survival and event-free survival. Next slide. So this is the secondary endpoints. We can say the secondary line of treatment percentage the patient may get in either arm. If you see the percentage wise, the radiotherapy treatment or the systemic therapy, whether it is salvage chemo, CAR T cell therapy, or stem cell transplant with conditioning chemotherapy, the percentage of each of this treatment is more in the R-CHP arm as compared to the Polatuzumab arm. So, so we can say that Polatuzumab arm, yes, it's a better as compared to the R-CHP in terms of event-free survival and the progression-free survival, but the overall survival might be both are similar. And there is a unblinding in terms of if patient in R-CHP arm having a disease progression, they can shift over to the Polatuzumab arm. Around 8 patients were switched over to the Polatuzumab arm during the study period. Next slide. So these are all safety profile of each arm, or we can say the side effects or complications almost similar in both the arm, whether it is Polatuzumab arm or R-CHP arm. But the percentage wise, febrile neutropenia or febrile illness is percentage wise is more in the Polatuzumab arm as compared to the R-CHP arm, and the grade 3 to grade 4 febrile neutropenia is more as compared to the R-CHP arm. Otherwise, all the basic side effects like anemia, constipation, nausea, vomiting, almost.
Dr. Ashish, can you please wind up, please? Yes. We are running short of time. Thank you.
Only 2 slides. Next slide. So this is the conclusion of the safety measures. So yeah, the grade 3, whether it is a high grade adverse effects, the percentage wise both are similar, and the discontinuation of the drug, whether it is due to the side effect or any dose reduction in the treatment arm, in either arm, the percentage wise is both similar. So yeah, next slide. So we can conclude that in the patient of intermediate risk to high risk, the patient which are DNABO, the Polatuzumab arm significantly increase the progression-free survival, and the adverse effect and the adverse side effect is similar in both the arms. And we can conclude that the data support use the Polatuzumab in along with R-CHP in patient with untreated DLBCL. So this is my last slide, and the last slide will show the post analysis. I have added this one slide from my point of view. Next slide. Yeah. So so this is the available. Actually, this is not available in India, but this will come in 2 strands, 30 mg and 140 mg, and the post analysis is almost 1.8 mg per kg in each cycle. Almost if 70 kg patient is almost the dose is around 120 to 130. So one vial in each cycle, the cost is around 12,60,000. So in India, at least we can give a salvage along with the auto transplant. So yeah, but
thank you so much, Dr. Ashish. Thank you for your excellent presentation. And without wasting time, I invite our next speaker, Dr. Deepak Shukla. We all know him well. He will be discussing on 2 topics. One is about the double-hit lymphomas, and other one about the JUMA-7 trials. So over to you, Dr. Deepak Shukla.
Thank you, sir. I'll share my slide. Okay. Are my slides visible, sir?
Yes, sir.
Yes, so it is visible and you are audible.
Yeah. So these are the 2 trials I'll be discussing now. So the first one is the Alliance trial. This was a randomized phase 2/3 study of DA-POCH-R with venetoclax in patients with previously untreated double-hit lymphoma. So we know that double-hit lymphoma are an aggressive high-grade B-cell lymphoma with MYC and BCL2 or BCL6 rearrangement, and they are associated with poor outcomes with R-CHP. And DA-POCH-R, based on the favorable retrospective data, is considered current standard of care. A phase 1 study has shown preliminary anti-tumor activity of combination of venetoclax with this regime, and but it was associated with high rates of grade 3-4 toxicity. So as a follow-up phase 2-3 study, the alliance trial was undertaken to evaluate this combination of venetoclax with RDA-POCH in patients with double-hit lymphoma and double expressor lymphoma. The current analysis which I will discuss is for the double-hit lymphoma patients with or without venetoclax with DA-POCH-R. So this was a open-label phase 2-3 trial for patients with double-hit lymphoma. Initial data cutoff was planned for July 8, 2021, but because of the safety signal, the data was released earlier in December 2020. So the patients who were enrolled were patients with double-hit lymphoma with the performance status less than 2 with adequate organ function reserve, and the DA-POCH-R in the standard protocol was used in the standard of care arm, while venetoclax was given on days 4 to 8 in cycle 1 and days 1 to 5 in cycle 2 to 6 for up to 6 cycles. The primary endpoint was PFS. The secondary endpoint was overall survival, safety, and response rate. So if we look into the baseline characteristics, both arms were well meshed. Approximate median age was close to 65 years in both arms. So if we look into the treatment as administered, the addition of venetoclax led to fewer patients in the DA-POCH arm had dose escalation when venetoclax was added. So if we look in the table, only 22% could undergo a dose escalation, which is an important part of the treatment of the DA-POCH-R protocol as such if we discuss, while reduction to -1 or -2 were seen more commonly in patients in which venetoclax was added as compared to when DA-POCH-R was given alone. There were more omissions of venetoclax seen in the arm when the venetoclax was added. Also, dose reduction, though if we look into the table, there were more in DA-POCH-R, but as I'll discuss, there were toxicity concern for which the trial was halted early. So I'll move to the next slide. So the reason for stopping this trial and releasing the data early was the occurrence of grade 5 adverse events in less than 30 days. So in the standard of care arm, 3.3% patients had a grade 5 adverse event, while in the venetoclax arm, it was 17.1%. So out of 35 patients, 6 patients expired. The reasons were sepsis, cardiac arrest, lung infection, hypoxia, and COVID-19. If we look into the responses at the end of the treatment, in the ITD population, DA-POCH-R did better because fewer patients were able to complete the venetoclax treatment, and overall, the ITT population overall response rate and CR rates were lower when venetoclax was added to DA-POCH-R. The efficacy outcome, if we look, the PFS was better when DA-POCH-R alone was used, while it was inferior in terms of PFS, OS, and duration of response when venetoclax was added. So the key conclusion was that of the alliance trial is the addition of venetoclax to DA-POCH-R was associated with excess treatment-related toxicity and mortality, triggering early closure of the double-hit lymphoma cohort. However, investigators concluded that the DA-POCH-R performed well as a control arm with limited follow-up. And furthermore, study demonstrated feasibility of conducting a prospective cooperative group trials in the setting of double-hit lymphoma. So I'll move to the next trial, the ZUMA-7. This was a randomized phase 3 trial of second-line ASCEMBL versus the standard of care in relapse refractory large B-cell lymphoma. So the current standard of care in the second-line treatment for curative setting in relapse refractory large B-cell lymphoma is high-dose chemotherapy in patients who respond to salvage chemotherapy given as consolidation. And many patients cannot receive this treatment because obvious reason they do not respond to the salvage chemotherapy. So ASCEMBL is a autologous second generation CD19 directed CAR T cell therapy, and it is approved in second line for these indications. So ASCEMBL may provide more benefit if used in earlier lines of therapy. That was the key question that was asked. And the current study reports the primary efficacy findings of ZUMA-7, which compared second line ASCEMBL versus the standard of care in patients with relapsed refractory large B-cell lymphoma. So ZUMA-7 was a global multi-center randomized phase 3 trial in patients who were 18 years or more with large B-cell lymphoma with performance status 0 or 1. Patients need to have a refractory disease or relapsed disease less than 12 months after receiving the adequate first-line anti-CD monoclonal antibody treatment with anthracycline treatment with an intent to proceed to high-dose treatment followed by autologous stem cell rescue. The 359 patients were randomized equally, 180 patients approximately in both arms. In the ASCEMBL arm, patient received the lymphodepleting chemotherapy followed by autologous ASCEMBL infusion, while in the standard of care arm, patients received 2 to 3 cycles of investigator selected protocol, and patient who had a CR or PR proceeded to high dose treatment followed by autologous stem cell rescue. So if we look out of the 180 patients in the ASCEMBL, nearly, I'll show subsequently, that nearly 90% patients went on to receive ASCEMBL, while in standard of care, if you look in the 179 patients, 64, close to 33% went on to receive the high-dose chemotherapy followed by autologous stem cell transplant. The primary endpoint of this trial was event-free survival, while these were the other secondary endpoints. The trial was reported at a median follow-up of close to 2 years, the key secondary endpoints being overall response rate and OS. So again, as mentioned, in the 180 patients who were enrolled for ASCEMBL infusion, nearly 170%, more than 90% went on to receive the ASCEMBL. While in the standard of care arm, out of the 179 patients, only 64 went on to receive high-dose chemotherapy and autologous stem cell transplant. If we look into the baseline characteristics, it was well matched with the median age of close to 60 years in both arms, and the other characteristics were also well matched. If we look into the event-free survival, that was the primary endpoint. The median event-free survival for ASCEMBL was 8.3 months as compared to 2 months in the standard of care arm. The 24-month event-free survival was 40.5% for ASCEMBL as compared to 16.3% in standard of care arm, and the use of ASCEMBL reduced the hazards of an event by close to 61%, and the p-value was significant. If we look in terms of overall response rate and overall survival, which were key secondary endpoints, the overall response rate was more with ASCEMBL. There were more CRs, nearly double, nearly equal PRs. The median overall survival at this 2-year time point was not reached for ASCEMBL, while it was close to 3 years with standard of care, and it was not significant at this point. But one must remember that 56% of the patients in the standard of care arm receive subsequent cellular immunotherapy of protocol, which may confound the overall survival benefit if possibly in future, if we are not seeing this, then possibly the significant crossover could be one of the reasons. If we look into the CRS and neurological events, which we know are the common adverse events associated with CAR T cell therapy, so any grade of CRS was seen in close to 90% of the patient, most common being pyrexia followed by hypotension, sinus tachycardia. For managing CRS, most common agent used was tocilizumab followed by corticosteroids, and less than 10% required vasopressors. The time of onset for 3 days. If we look into the neurological events with ASCEMBL, 60% have had any grade neurological event with use of ASCEMBL. The most common being tremor, confusional state, and aphasia. And for managing the neurological events, steroids were commonly used in 1/3 of the patient. The onset was slightly later as compared to CRS. It was 7 days, and the median duration was 9 days. So the key conclusion from the investigator was at a follow-up of close to 2 years, ZUMA-7 met its primary endpoint, demonstrating a statistically significant and clinically meaningful improvement in event-free survival with second-line ASCEMBL versus standard of care in relapsed refractory large B-cell lymphoma. ASCEMBL showed improved event-free survival and response rate versus standard of care. There was greater than 4-fold increase in median event-free survival across key subgroup, 33% higher overall response rate, double the CR rates. Nearly 3 times more patients randomized to ASCEMBL received definitive therapy versus standard of care, and ASCEMBL had a manageable safety profile consistent with prior studies. And investigators conclude that ZUMA-7 results mark a paradigm shift whereby ASCEMBL should be considered the new standard of care for patients with second-line relapsed refractory large B-cell lymphoma. Thank you.
Excellent presentation, Dr. Deepak. And please stay for the panel discussion. And our next speaker is Dr. Annu Rajpurohit. Dr. Annu Rajpurohit is new addition in Jaipur Oncology Group. Welcome to Rajasthan Oncology and to this webinar, Dr. Annu. And I may request you to please start your presentation.
Thank you, sir, for the kind introduction. Thank you, organization team, for giving me this opportunity. I would like to share my screen. I hope it is visible to all.
Yes, it is visible. You are audible.
Okay, so I start with my first slide, which is Citadel trial. It is a phase 2 trial of parsaclisib, which is PI3K delta inhibitor in patient with relapsed refractory follicular lymphoma. So, as we all know, that relapsed refractory follicular lymphoma, they require more effective treatments. Though the first-line therapy is very effective, but the relapse is common. And with each subsequent therapy, we see the shorter duration of response. So, till date, 4 PI3K inhibitors are available, which are copanlisib, duvelisib, Idela, and umbralisib. Into the addition, the newer molecular is parsaclisib. It is next generation PI3K inhibitor with highly selective for the delta, which minimizes the risk of hepatotoxicity. So current studies report primary efficacy analysis of phase 2 study of parsaclisib in patient with relapsed refractory follicular lymphoma. So this is a multi-center open label phase 2 trial. The inclusion criteria were the confirmed relapsed refractory follicular lymphoma patients who received 2 or more prior systemic therapy, but no prior with PI3K or gluten kinase inhibitors with ECOG PS between 0 to 2, and those who were ineligible for the transplant. So they divided these patients into 2 categories by the dosing schedule. First one is weekly dosing group. Parsaclisib was given 20 milligram daily for 8 weeks, followed by 20 milligram every week. And the second group included daily dosing, same as first, parsaclisib 20 milligram OD for 8 weeks, followed by 2.5 milligram continuous dosing. And they analyzed the data between 2 groups. The first one is the daily dosing and the all treated patients, which include patients who switch from weekly dosing to daily dosing. The primary endpoint was overall response rate, and the secondary was CR rate, duration of response, PFS, and OS. If we see the baseline characteristics, the median age was around the 70 in the both the arms. Male were almost half. If we see the staging, almost 80% patients were in the stage 3-4 stage. The ECOG PS was less than 1 in the almost 95%. The FLAPI category more than 3 in the half of the patients. This is the response and the PFS curve. We can see the curves are parallel. They are equal in all treated and the daily dosing group. If we see the overall response, it is almost 77 and 75 in both the groups. CR in almost 20%. The PR is almost 60%, and the stable disease we see around 15%. And the median duration of response in months was around 14.7 months. This is the waterfall curve. We can see the excellent response rate with this molecule in both the arms. So these are the adverse events. So all type of adverse event happened almost in every patient in both the group. Diarrhea, nausea, fatigue, pyrexia were the common. In hematological side effects, cytopenias were common. And the second being increase in the liver enzymes. So if we see serious side effects, so they are diarrhea, colitis, and pneumonitis. 2 deaths happened because of the SJ syndrome and the pneumonia. Those interruption, reduction, discontinuation happened similarly, were similar in both the group. 50% patient they did the interruption in the half of the patient. Reduction happened in 20%, and the discontinuation happened in the 1/4 of the patient. The cause being most common the diarrhea, followed by neutropenia. So conclusion is that parsaclisib, a newer molecule, has a rapid durable response in patients with relapsed refractory follicular lymphoma with 78% of overall response rate, 15.7 months of duration of response, and the 15.8 months of PFS. So it is well tolerated because of its highly selectivity towards the delta and had a manageable safety profile. Now coming to my second presentation, which is BELINDA trial. It is a phase 3 trial of CAR T-cell therapy, which is T-cell versus standard of care as a second-line treatment for relapsed refractory aggressive B-cell non-Hodgkin lymphoma. As we all know that aggressive B-cell lymphoma who experience disease relapse or refractoriness less than 12 months of initial treatment have a poor prognosis. The current standard of care is to give platinum-based chemoimmunotherapy followed by transplant. So in this trial, they did CAR T-cell therapy in second line and they compared it with the standard of care. So this is the study design. It is a multi-center randomized open label phase 3 trial. Inclusion criteria were all the adult patients were taken with confirmed aggressive non-Hodgkin lymphoma relapse refractory within 12 months of first line therapy, those who were eligible for the transplant and with ECO-PS 0 to 1. So first they did screening leukapheresis. They divided into 2. First went for CAR T-cell therapy and second one is the standard of care. So first they did bridging platinum-based chemotherapy plus lymphodepletion followed by the infusion of the CAR T-cell therapy. And in second arm, they did first PCT, means platinum-based chemoimmunotherapy, followed by the transplant. First analysis they did at the week 6 by doing the PET-CT and second one was done at the week 12. Primary endpoint was event-free survival, and it is defined as stable disease or progressive disease as per BIRC at the 12 weeks. Secondary endpoints were overall response rate, safety, and cellular kinetics. These are the baseline characteristics. More than 65 age was seen in the more than half of the patients. Almost 60% of the patients were male, and the 30% of the population from the US, and 70% are from the non-US. If we see the race, the Asian, they include almost 12%. And if we see the disease subtypes, DLBCL NOS is most common, around 60 to 70%, followed by double hit, triple hit, PMBCL, and the follicular grade 3B. This is the number of platinum-based chemoimmunotherapy cycles and the median time to CAR T-cell therapy infusion. So 0 was given in almost 17% of the patient, 1 cycle was given in 36%, and more than one cycle was received in the 50% of the CAR T-cell therapy, compared to the standard of care arm, where the almost 97% patient received more than 1 cycle of platinum-based chemoimmunotherapy. So this is the result. Event-free survival, all patient primary endpoint. If we see Desargen-Lexucel, which is CAR T-cell therapy, it is around 3 months. It is similar in the standard of care arm, it is 3 months. If we see the hazard ratio, it is 1.07, which indicates it is not superior to our standard of care arm. So adjusted HR, adjusted to potential imbalance between arms regarding pre-specified covariates. 6 patients responded to CAR T-cell therapy but developed stable disease or progressive disease prior to or soon after infusion and were captured as EFS event. So this is again showing the result. If we see the result, progressive disease was seen in 1.2, the ratio in CAR T-cell therapy. If we see the, according to disease diagnosis, it is 3.5 in DLBCL NOS, 4.7 in PMBCL, 2.8 around in HGBL, which is high-grade B-cell lymphoma. This is the response. First is at 6 weeks and second was done at the week 12. If we see at the 6 weeks in CAR T-cell therapy, it is almost 40% overall response rate, and in standard of care arm, it is 53%. If we compare it with the 12 weeks, it is almost half, like almost 50% in CAR T-cell therapy and 42% at the standard of care arm. If we see the best overall response rate, the CR rate is almost 11%, which is lesser than the standard of care arm. But if we see the assessment at the 12 weeks, then it is similar in both the arms. If we notice the progressive disease, this is more in CAR T-cell therapy arm. It is almost 25% compared to 13% in standard of care arm, which is a catchy point here. If we see the safety profile, all treatment-related side effects happen almost in more than 90% in both the arms. And if we see the hematological disorder like cytopenia, they are more or less equal in both the arms. Deaths happen in 30% in CAR T-cell therapy arm and 28% in the standard of care arm. So what is the conclusion? As we know that in patients with early relapse refractory aggressive B-cell NHL, the use of R-T-cell therapy as second-line therapy had no significant impact on event-free survival compared to standard of care arm. Progressive disease at week 6, which we have seen, which was almost double than the standard of care arm, it indicates the need for the effective bridging prior to CAR T-cell infusion in these patient population. So this study suggests the further new input in the design of the future trials for the second-line CAR T-cell therapy with effective bridging regimen to bring the better result. Thank you.
Thank you so much, Dr. Annu, for your excellent inputs. And now we will be moving to the panel discussion. And we will restrict ourselves to the 6 abstracts which you all three have presented. And we try to discuss the science only, and then we take some inputs from our senior colleagues that what is the implication of these studies in our clinical practice. So to introduce our panelists for today, Dr. Upendra Sharma is Senior Consultant Hematologist at Bhagwan Mahavir Cancer Hospital in Jaipur. Dr. Ajay Yadav is a good friend of ours, working with Mahatma Gandhi Medical College. He's Associate Professor. Dr. Deepak Shukla, Dr. Annu and Dr. Ashish has already been introduced to you. So I'll share my screen for the panel discussion. I think my slides are visible to you.
Yes, sir.
Yes, sir.
So let me go to first slide. Yes. So the first discussion was about the evaluation of MRD and CT imaging following the first line treatment in patients with DLBCL. So I'll start with Dr. Ajay Yadav. Dr. Ajay, can you unmute and be visible to us?
Sir. Good evening, sir.
So, yeah, very good evening, Dr. Ajay. So, Dr. Ajay, what is your thoughts on this particular study, that the importance of MRD, and these are the slides just for your reference. We all know that CR is common in almost 60% of the patient, but relapses are also common in 40% cases, and early detection of these relapses are very important for us. And how can we extrapolate the data of MRD in management? So these are the conclusions for you of this study.
Sir, main purpose of MRD is that if we can intensify the treatment if there is MRD positivity.
Yes.
And second, if we can detect the disease earlier when it become radiologically or clinically evident. But as in this study, we found that there are few patients who were having clinically and radiologically there was disease, but MRD was negative in those patients. So this is so these data are not convincing for me.
Absolutely right. Dr. Ashish, if correctly remembered, it was around 24% of the patients, they did not have a sort of, it was falsely reported MRD. Dr. Ashish?
Yes, sir. Your voice is breaking, sir. I'm not able to listen.
Yeah, is it okay now? Am I audible now?
Yeah, sir. Yes, sir. Yeah.
So what are your thoughts on implication of this study in our clinical practice? You are convinced or you feel something is lacking?
Sir, even though MRD is positive and clinically as well as radiologically the disease was not able to means we cannot able to assess the disease. So ideally, if disease was relapsed, we have to rebiopsy the disease and confirm the disease, and then only we will plan the chemotherapy. So I am not convinced with the result. Even though the MRD is positive, patient was in remission symptomatically, patient was in asymptomatic, and imaging wise there was no disease. So we can follow up the patient even though MRD was positive, sir.
Absolutely right. So I think currently this is too premature for us to sort of implement this study. The next study which you presented, Dr. Ashish, about the POLARIX trial, and you mentioned about previously untreated diffuse large B-cell lymphoma, and what they have done replacement of vincristine from this monoclonal antibody, and we have seen the results of this trial. So the PFS was again impressive and it was suggestive of good. EFS was also good, but overall survival results were almost same. And if we see the outcomes, then also we can see that the systemic therapy was needed in less number of patients in the monoclonal antibody arm, Polatuzumab arm, as compared to the R-CHP arm. And lesser number of patients, they went on subsequent therapy. So, Dr. Upendra, are you there? Dr.
Yes,
Upendra
sir.
Sharma has joined.
Sir, thank you for this nice, wonderful meeting. So this trial using Polatuzumab, so there was an event-free survival benefit for this for such patient, but there was no overall survival benefit when we have seen this using this drug when this drug was replaced with vincristine. So yes. Most of these patients, they have better event-free survival. As such, less of these patients, they require subsequent second line of therapy as compared to those patients who are receiving R-CHP.
So the EFS carries significance, or you are not happy with the event-free survival, in fact, in this subset of patients?
So, sir, event-free survival is important aspect because it denotes that we are free from that
yes.
This disease. So if we can prolong our event-free survival for those patients, so the patient we can improve their quality of life.
Absolutely right. So I think the event-free survival in first-line treatment is very important, and these patients will not be relapsing. And the subsequent therapies we know is more complicated, in fact. So whatever best response we can achieve in first line, we all put our full efforts for that. Dr. Deepak Shukla, any input from your side on this?
Yes, sir. So only issue is still the follow-up is means I think less than 3 years. Okay, yes. So we do not know whether the events will continue to last. Okay, so we possibly require more follow-up data over the next 2 to 3 years. Let's hope the event-free survival holds up, and possibly it will be difficult to show an OS advantage. But even if event-free survival is holding, I think it will become a standard of care, one of the standard of care.
Right. Thank you. Dr. Ashish, any inputs that why they did not use this Polatuzumab along with the vincristine? Why did they remove vincristine?
So see, both drugs are neurotoxic. Actually, the mechanism of action of Polatuzumab and vincristine is same. They are inhibiting the macrotubule formation. So they can precipitate or they can cumulatively increase the neurotoxicity. That's why vincristine is replaced in the Polatuzumab arm, sir, just to avoid the neurotoxicity.
Dr. Annu, any inputs from your side?
Yes,
yeah,
sir.
please.
So first, the catchy point is event-free survival. Yes, it gives the extra edge for this drug. But I would like to ask my own seniors, is it available like in India?
No.
Not available. So we quickly go to the next presentations. So this all we have discussed. And the next is about the study which is Alliance 51701 randomized phase 2, phase 3 study on DA epoch R plus minus venetoclax in double hit lymphomas. So this was the background presented to us, and we all know about DA epoch R is little toxic, and we all have used, of course, in our various clinical settings, and we have seen the safety point also, and the efficacy also is visible, and these are the conclusions from the authors. So again, let me start with Dr. Ajay Yadav. Dr. Ajay, what are your thoughts on this particular study? That addition of venetoclax is safer or?
So DIPOC is already a toxic regime, so it is very difficult to manage the toxicities. And with the addition of venetoclax, the authors found that there was very high toxicity, including grade 3 and 4 toxicity and deaths. So it is very difficult in our setting to manage these toxicities.
Very right. And if you see, the doses given was 600 milligram. So I'm scared. In fact, Dr. Upendra, any thoughts on the doses of venetoclax?
Yes, sir. Dose of venetoclax was very high in this subset of patients. And as such, we just Dr. Ajay has elaborated. DIPOC R is a very toxic regime. And in this trial, because of the addition of venetoclax, most of these patients were not able to complete their course of chemotherapy, and that hampered their overall survival, event-free survival. All the aspects were down as compared to those patients who received those adjusted epoch R. So most of these patients, they with exclusion of venetoclax, most of these patients they completed their full chemotherapy regime and tolerated that regime well. So adding venetoclax lead to more harm to these patients, leading to poor results, outcome, and more deaths. But for grade 5 toxicity, 6 patients died after 35 because of sepsis and other complications. So that because of that, there's a premature termination of this trial.
I think that is very important, that just based on the Western data, we should not subject our patients on these very high risk protocols.
These are Western patients, and
yes,
if we can exploit in Indian patient, mortality rate will be very, very high.
So I think that is very important.
The benefit of doing a epoch R with whatever is lies in the dose adjustment. So when we added venetoclax, we were not actually able to dose adjust also. So this was also negative, and possibly we know that double hit and triple hit are a very bad disease subset. Possibly in future, if we have to choose based on the results per se of DA-POCH-R in a fit patients, we have some data supporting, prospective data supporting its use. That could be the only takeaway, and as such, the addition of venetoclax did not work. So it was a negative trial.
So most of these patients, around 73% of these patients, Dr. Deepak, they were able to escalate their dose as a epoch in. So they were able to escalate their regime by one level as compared to those patients who received venetoclax. So substantial number of patients author were able to increase the dose of the IPOC.
Yes, sir. Yes.
Dr. Annu, any input from your side? You are mute. Please unmute yourself.
Yes, sir. So I agree with all that it's very toxic to combine all this, because our epoch itself, it's very difficult to manage in our setting. So I'm also not convinced with this trial.
Thank you. Thank you so much. So the next trial is Juma 7. And Juma 7 again in a trial of the second line treatment of CAR T cell therapy versus standard care. So Dr. Annu, let me start with you only, that you are convinced with the trial, or you feel that there can be some improvement in the trial design?
So sir, I feel, yes, it is convincing, but again, we need to have our own data in our setting.
Dr. Upendra, any thoughts from your side, that you are happy with the trial design, or you feel something better? could have been done?
So, sir, in this trial, I think most of these patients using XSL, they had better response rate as compared to the standard of care. I think it was more than 1/3 of these patients they had response rate. So your overall response rate, event-free survival was double with this regime as compared to standard of care, 16.3%. So that is increasing with the standard of care. If we can improve our this event-free survival, so these results are increasing, and I think more and more trials are. As such, India, we are lacking in this aspect. Artificial therapy in India, if it would have been available, yes, because standard of care, most of these patients, if they relapse within say a year of their first remission. So if patient relapsing less than 12 months, they have very dismal outcome. Most of these patients didn't achieve their second CR with the standard of care chemotherapy. So for those patients, yes, this is really a good option using CAR T cell therapy, because for these patients we have seen they don't have good response with any sort of therapy.
I think that is very, very important to take home, that in patients who relapse faster, therapy makes a huge difference. Dr. Deepak, you also agree to this, or you want to add something else?
Yes, sir, I completely agree. Actually, if you look into the standard of care arm, so patients who are either refractory of relapse less than 12 months, if we look into the historical data, the results with autologous stem cell transplant is less than 20%. So for patients who are relapsing after 12 months, possibly the results are better with autologous close to 40-50%, but for refractory disease or early relapses, the data with autologous transplant, the treatment which is available to us, it is not having very good results. So though we do not have availability of this, but definitely it is a practice changing data. So I think it is really means good data in this poor subset of patient.
Absolutely agree. So the next was about the BELINDA trial. And Dr. Annu, let me start with you only again, that any inputs from your side about this trial? We have seen that less than 12 months initial treatment had a poor prognosis, patient relapses, and the second line standard of care options, including platinum-based chemotherapy, followed by autologous high-dose chemotherapy, and transplant remains the option.
Yes, sir.
So what are your thoughts on this particular trial?
So based on prior trials which were done with the other PI3K inhibitors, if we compare this, because it is okay, sorry, it's BELINDA. Okay, so what I feel, sir, because at week 6 we found that the progression of the disease was almost double if we see compared to the standard of care, is almost 25%. So it's still catch our attention to the point that we need still something in form of chemotherapy as a bridging therapy to make a better result in CAR T cell therapy arm.
Dr. Deepak.
Yes, sir. So, sir, I reviewed these. So now we have 3 trials in this area. So the first, which I discussed, was the ZUMA-7, which was a positive trial. The BELINDA trial, again, it is a CD19 directed CAR. It was a negative trial. And we have a third trial, transform trial with Lisa-cell. So that is also a positive trial. So the subset of patient they have enrolled is similar, means all have enrolled refractory patient. The possible reason what I could see is in the BELINDA trial, the infusion of autologous CAR T cell was requiring close to 60 days, means 57 days it was required. While in the ZUMA-7 trial, it was close to 30 days. So more patients received the planned autologous CAR T cell earlier as compared to the BELINDA trial. Also, there is a difference between BELINDA as well as ZUMA-7. In ZUMA-7, they have allowed only use of steroids prior to giving this CAR T cell. While in the BELINDA trial, they have means given patient 1 or 2 cycles. And by giving 1 or 2 cycles chemotherapy, that was possibly one of the reasons why the infusion of CAR T cell was delayed. So And the third trial, again, if we look, is the transform trial. Again, the results of transform trial, the Lisa cell is similar to what is seen with Zuma 7. So unluckily, BELINDA trial, this drug is from Novartis. This failed as compared to others. The possible reasons I mentioned just now.
I think that is very, very important, Dr. Ajay. Dr. Ajay? Is Dr. Ajay with us? So anyway, Dr. Upender, any conclusion that we will be able to have this
Dr. Deepak has very elaborately explained all the aspects. So more and more exposure of CAR T.
What I'm asking, Upender, in Jaipur, in Rajasthan, in Marudhara, can we accept CAR T cell therapy in near future during our lifetime? Yes or no?
Sir, yes, dreams are there, yes, and we will fulfill our dreams.
Yes, so we are very hopeful that we will have some good drugs. And this was
last 15 years, we have seen good updates and good medicines in hematology. Previously, what we are using 15 years back, now we feel lucky to use most of newer drugs in hematology. So I think, yes, time will change and we will be able to use CAR T cell therapy in future.
Thank you so much. And with this, we conclude the first panel discussion. I thank Dr. Ashish, Dr. Deepak Shukla, Dr. Annu for excellent presentations and their inputs, and Dr. Upender and Dr. Ajay Yadav for their expert comments in the panel discussion. So now we move from lymphoma to leukemia, and to start the first session, I invite Dr. Ankit Agarwal.
Hello.
Senior consultant medical oncologist at Gitanjali Hospital, Udaipur.
I think there is some network issue. One second, sir. I'll share
I think, Ankit, we have logged in from 2 devices.
Sir, actually, there have been some issues with my mobile as well as my. I'll just share my. Can I share my screen, sir?
Yes, yes.
Right, sir. Thank you.
I felt sometime that I'm having diplopia or what, because I can see two Ankit Agarwal. Yes.
Am I visible, sir?
Yes, it is visible. You are audible. Please go ahead.
Thank you, sir. Thanks a lot for the opportunity, sir. Okay, so moving on from lymphoma to leukemia, what we will discuss in the next 5 to 7 minutes are two studies. The first one is the ASCEMBL study, in which we will be discussing about the TKIs from the second line, third line, or fourth line. What is a good TKI that we can rely on? So this trial is an extended. This update is an extended update of the ASCEMBL trial, a 48-week update of the results from the phase 3 study of a STAMP inhibitor, asciminib. The STAMP inhibitor is the asciminib which was compared to bosutinib for CML-CP, previously treated with 2 TKIs. So, as I said, it is an extended update. Initially, the 24-week update of this trial, wherein asciminib was compared to bosutinib, had shown that the MMR rate of at 24 weeks was 25% versus 13% in the asciminib arm as compared to the bosutinib arm, which was quite significantly different, and thus this had led to the approval of asciminib by FDA for treatment of those patients who have CML-CP and are resistant to at least 2 prior TKIs. It was also shown in the prior update that the rates of adverse effects in asciminib arm was lesser as compared to the bosutinib, and thus the discontinuation of treatment was also lesser as compared to bosutinib. So just a brief update about what was the study design. So all those patients who had been diagnosed as CML-CP, who had received at least 2 prior TKIs or were intolerant to TKIs, either failure or intolerant, were randomized to 2 arms, the asciminib arm, in which asciminib was given at a dose of 40 BD, and bosutinib was given at a dose of 500 OD. The exclusion criteria was T315I or B299L mutation, because bosutinib is not contraindicated in these two mutations. And the primary endpoint was the major molecular response rate at week 24, and the secondary endpoints being MMR rate at week 96, the safety, tolerability, complete cytogenetic response rates, and the time to treatment failure rates, PFS and OS. So the patient's characteristics, as of now, for 48-week update has suggested that at least 56% of the patients in the asciminib arm are still continuing treatment, whereas in the bosutinib arm, only 22% of the patients have been able to continue treatment. The main reason for discontinuation is lack of efficacy in 23% of the cases of asciminib arm, whereas 35% of the cases in bosutinib had lack of efficacy. The reason, if you talk about the adverse effects, 5% of the patients, 5.7% of the patients in asciminib arm had discontinued treatment, whereas 23% of the patients in bosutinib arm had to discontinue the treatment because of the side effects. Talking about, as I said, the major molecular response, the rate of MMR at week 48 in the asciminib arm was 29.3% versus 13.2%. This was maintained even after 24 weeks. So almost similar results at 24 weeks at when we talk about 48 weeks. Also, when we talk about at what line should we use asciminib, when asciminib was used either in the third, fourth, or the fifth line, the MMR rates were almost maintained as compared to the bosutinib arm, wherein if it was used at the fifth or later lines, there was no MMR rate at 48 weeks. So deep molecular response also was significantly better in the asciminib arm as compared to the bosutinib arm. The MR4 was 10.8% at 48 weeks, MR4.5 was 7.6% at 48 weeks, as compared to 3.9 and 1.3%. Treatment failure 48% in asciminib arm as well as compared to 80% in the bosutinib arm. Talking about the side effect profile, the side effect profile also was better in asciminib group as compared to the bosutinib group. The grade 3 side effects which led to the treatment discontinuation was 6.4% in asciminib arm as compared to 18% in the bosutinib arm. Hematological toxicity was slightly higher in the asciminib arm as compared to bosutinib. 29.5% of the patients had thrombocytopenia. But majority of the patients who had hematological toxicity had the toxicities within first 6 months of the use of asciminib, and after 6 months, the incidence of incidence of thrombocytopenia or any other hematological toxicity like neutropenia and anemia was almost to the tune of 0. There were few patients who had arterial occlusive events in the asciminib arm, but it was very uncertain whether these patients had these arterial occlusive events because of asciminib or not, because they had already received a prior TKI like nilotinib and ponatinib. So a meaningful comparison was difficult in the patients who had these type of side effects. So conclusions, this update has shown that the efficacy of asciminib has sustained as compared to the bosutinib arm among patients who have received treatment like at least 2 TKIs at week 48. The MMR rate is 29.3% versus 13.2% at 48 weeks. And the deep molecular response also significantly higher, 10.8 versus 3.9% MR4, MR4.5, 7.6% versus 1.3%. And more patients remained on treatment, 56% versus 22%. Thank you. May I move on to the next slide, sir? Next topic.
Yes, sir.
Thank you. I'll share my slide. Just give me 1 second. Okay, one more interesting discussion or one more interesting analysis that has been given to me today is low dose dasatinib versus the standard dose dasatinib. So moving on from a third line treatment in CML to upfront first line treatment in CML. So this was a kind of an observational study in which the selection bias or the confounding factors were basically reduced by a propensity score analysis. So this analysis was a low dose dasatinib versus the standard dose dasatinib in first line treatment of CML chronic phase patients. So just a small background, safety and efficacy of low dose dasatinib has been demonstrated in patients with newly diagnosed CML. There are no randomized studies which have compared the standard dose versus low dose dasatinib. So uh, uh, what this analysis has suggested is 50 milligram a day of dasatinib versus a standard dose that is 100 milligram. How does they compare with each other? So the response analyzed for patients with newly diagnosed CML-CP who were receiving 50 milligram and the standard dose 100 milligram, there was a propensity score matching which identified 77% of 77 patients in each cohort. And all these patients, they did not have any significant baseline difference. And the assessment was by the FFS, EFS, TFS, OS, and the safety. So this was the study design. This was the baseline characteristic, 77 patients pre-matched and post-matched by the propensity score analysis. They were all matched. So this was the basic outcome. At 4 years, the freedom from failure survival, event-free survival, treatment-free survival, and the overall survival was 89% in the dasatinib arm, where 50 milligram were used as compared to the 77%. 95 versus 92% of the patients had a event-free survival at 4 years. Almost all the patients had treatment-free survival at 4 years. The p-value not significant between the two arms, although it's an observational study with a propensity score analysis, but still there have been we see a lot of patients who do not tolerate 100 milligram of dasatinib, and we can easily use 15 milligram in these type of patients. So also the outcome when we talk about the molecular responses, the major molecular response at 36 months was 92% in the patients who had been using who were given 50 milligram of dose, and deep molecular response MR 4.5 was seen in 77% of the cases. Talking about the safety profile, these patients who, when they were compared for the safety profile, the side effect profile also was not very significant. Although we somehow see some patients, they are not able to tolerate 100 milligram of a dose, but here most of the patients had almost similar side effects when we talk about the hematological side effects. Pleural effusions were slightly higher in those patients who had 100 milligram dose, but not significant. So when we talk about the patients who had, now what was the average dose that was given to these patients? If we talk about mean dose in the fasting, the mean dose in 12 months was 49 milligram for those patients who had received 50 milligram of dasatinib, and the mean dose was 78 milligram for the arm where dasatinib was used at 100 milligram dose. Now, those patients who had been given 100 milligram of dasatinib, those patients who had received 100 milligram of dasatinib, approximately 43 people, 56% of the cases remained on 100 milligram dose, whereas 17% had reduced dose of 70 to 80 milligram. So this is the conclusion. In patients who have been newly diagnosed as CML-CP, the propensity score analysis showed a comparable efficacy with low dose dasatinib versus the standard dose dasatinib, a 4-year OS of at least 95% in both the approaches. But this trial has not shown any data as to what will happen to those patients who have a high risk disease. So before using dasatinib at a low dose, it is very important to categorize the patient, whether the patient is high risk or low risk. So especially in low-risk patients, probably we can 50 milligram is a good dose to use if we are concerned about the side effects. Thank you.
Thank you so much, sir. We'll now move on to our next speaker, Dr. Rohit. Over to you, sir.
Thank you. I'll just share my slides. Is it visible? Are my slides visible?
Yes, sir.
I'm audible, right?
Yes, sir.
Okay, good evening, everybody. I'm Dr. Rohit. I'm an assistant professor in Ananta Cancer Center, Udaipur. I'll be discussing two studies. The first of which is the Agile study, which is a phase 3 study of ivosidenib with azacitidine versus placebo with azacitidine in newly diagnosed IDH1 mutated acute myeloid leukemia. IDH mutations are generally found in around 6 to 10% of AML patients. It is considered to be a poor prognostic factor when seen with this disease. Ivosidenib is the first-in-class oral IDH1 inhibitor approved as a monotherapy for treatment in relapsed refractory AML and newly diagnosed AML in patients who are more than 75 years. In those patients generally that are not fit for any sort of intensive induction chemotherapy. AML management in older patients generally is complicated by comorbidities. So ivosidenib and azacitidine is found to be active and tolerable in newly diagnosed IDH1 mutated AML patients in the phase 1b study. And thus a phase 3 study was designed to compare ivosidenib with azacitidine versus placebo with azacitidine in newly diagnosed IDH1 mutated AML patients. This is the study design. So ivosidenib is given at 500 milligram orally QD, and azacitidine is given either subcutaneously or intravenously at 75 milligram per meter square. So centrally confirmed IDH1 status were taken with an ECOG performance status of 0 to 2. So this was the median age of the patients. As one can see, this consists of patients that are older. So the median age was about 76 with a range between 58 to 84. Almost well matched between both the groups. Most of the patients had a ECOG 1 or ECOG 2 performance status. Most patients had de novo AML, and most patients had intermediate or poor risk cytogenetics, and a median percentage of bone marrow blast was about 50% in most of these patients. So the EFS in the intention to treat population was not reached in both arms, but the hazards ratio was 0.33 in favor of ivosidenib with azacitidine as compared to placebo. The median overall survival was significantly better with 24 months versus 7.9 months with a very significant p-value and a hazards ratio of 0.44. So EFS benefit associated with ivosidenib was consistent across all subgroups: ECOG performance status, sex, race, cytological cytogenetic risk, as well as WHO AML classification. OS benefit was associated with IVO consistent against all in all subgroups. So basically, what this again shows was that significant overall survival actually showed even in the complete response as well as the CRH rates. As can be seen, that it is 47% versus 14.9%. CR plus CRH was 52 versus 7.6%. And the overall response rate also was 3 times better at 62.5% versus 18.9%. So definitely this drug actually plays a very, very important role in making a very poor subset of patients, because IDH mutations in AML is considered to be a slightly poorer risk subset. It makes these patients have pretty good survival in these elderly AML patients. One of the risks that we see with this IDH inhibitors is the differentiation syndrome. So the grade more than 2 differentiation syndrome was seen 14.1% versus 8.2%. Other issue is QT prolongation. Most of the other side effects like anemia, febrile neutropenias, or neutropenias were slightly more in the combination group as compared to the azacitidine group. But majorly we see fewer infections with the combination group as compared to the just plain azacitidine group. So it's well tolerated, as the addition of the drug does not really cause such bad side effects that could lead to a worrying factor, because these patients tend to be old and debilitated. So in patients with newly diagnosed IDH patients who are ineligible for intensive chemotherapy, ivosidenib with AZA is a significant, extends the EFS with a hazards ratio of about 0.33. OS and clinical response also were significantly improved. OS was more than 23 months as compared to 7.3 months. There were fewer infections also in the combination arm. And health-related quality of life was not very significant when adding this drug. So investigators concluded that this study demonstrated that ivosidenib with AZA provides clinical benefit in this patient population. So the next study that I will go through is the LACE-SWING study, which is a phase 3 study of gilteritinib with azacitidine versus azacitidine in patients with newly diagnosed FLT3 mutated AML, who are ineligible for intensive induction chemotherapy. So gilteritinib is an FLT3 TKI approved by the FDA for treatment of relapsed refractory AML with FLT3 mutation as detected by an FDA approved test. Limited therapeutic options for newly diagnosed patients with AML and FLT3 mutations who are ineligible for intensive induction therapy. Gilteritinib and azacitidine is shown to hamper tumor growth and induce apoptosis and differentiation of the FLT3 internal tandem duplication AML cell lines in preclinical studies. So this study investigated the efficacy and safety of gilteritinib and azacitidine versus azacitidine in adults with newly diagnosed FLT3 mutated AML who are ineligible for intensive induction chemotherapy. So this was the study design. It's a randomized open-label phase 3 study where gilteritinib was compared with gilteritinib plus azacitidine or azacitidine. The dose of gilteritinib was 120 milligram orally daily from days 1 to day 28. AZA was given from day 1 to day 7, as is the standard, 75 milligram per meter square, with the primary endpoint being overall survival and the secondary endpoint being event-free survival. So as you can see, more than 71% of the patients in this particular study were actually more than the age of 75 years. So this is a very frail subgroup that will not tolerate any sort of intensive chemotherapy, especially when you consider the Indian subgroup of population. Most patients had an ECOG performance status of 0 to 1, but one must note that almost 50% of the patients had an ECOG performance status of greater than or equal to 2. And internal tandem duplication was seen in 78%, and TKD mutation was seen in 18.9%. So if you look at the combination arm, the median time to first subsequent AML therapy was 8.2 months in the combination arm versus 4.5 months in the AZA. So 20% of the patients in the combination arm actually went in for subsequent therapy, whereas 44% in the AZA arm went in for subsequent therapy. So the median overall survival, there was not so much of a difference, the p-value not being significant. So it was 9.82 months versus 8.87 months. And the range, being 4.3 to 14 in AZA, being 7.5 to 12.5 in case of the combination. So if you look at the median EFS, it was 4.73 months versus 2.07 months. The hazards ratio is 0.896, but since it goes beyond unity, the p-value is not significant. The overall response rate was significantly better in the combination arm. The CR rates were significantly better in the combination arm, but the event-free survival is not statistically significant. So if you look at the adverse event profile, there is more incidence of febrile neutropenia. It is studied when you look at serious adverse events, grade more than 3, 35 versus 19. So that is one significant adverse effect that was significantly higher in case of the combination arm. The other side effects were actually well balanced between both arms, except for the febrile neutropenia part, which caused decreased neutrophils as well as decreased platelet counts to last a little bit longer. So the pharmacokinetics, gilteritinib trough concentration at steady state is similar to gilteritinib plus azacitidine and the gilteritinib arm. On day 15 of cycle 1, median gilteritinib trough concentration at steady state was 585 nanogram per ml in the gilteritinib AZA and the gilteritinib arm, which contrasts the 279 nanogram per ml observed with gilteritinib monotherapy in ADMIRAL trial in relapsed refractory AMLs. Median age in ADMIRAL was 62 years. Patients in abdominal study were eligible for high-dose chemotherapy. No observed correlation between gilteritinib trough concentration at steady states and response rates or grade of thrombocytopenia or neutropenia was seen. So the investigator conclusion was, in this phase 3 study, significantly higher CRC rates, but similar OS with gilteritinib plus azacitidine versus azacitidine alone in patients with newly diagnosed FNT3 mutated AML ineligible for intensive therapy. The median OS was 9.82 versus 5.87 with a non-significant p-value. Confounding factors potentially contributing to OS data include the use of subsequent therapy in higher proportion of patients with ECOG more than or equal to 2, patients in gilteritinib and azacitidine arm. Patients with ECOG PS 0 to 1 or high FNT3 ITD allelic ratio had greater responses to gilteritinib plus azacitidine. Safety profile was similar to that previously seen. Thank you.
Thank you so much, Dr. Rohit, for your excellent presentations. And our last speaker today is Dr. Surinder Beniwal. We all know Dr. Surinder Beniwal is from Bikaner, and he is currently a professor in the Department of Medical Oncology at Acharya Tulsi Cancer Institute. Thank you so much, Dr. Surinder, for accepting our invite. And Dr. Surinder will be discussing 2 trials on CLL studies. Over to you, Dr. Surinder, please.
Thank you very much, Lalit Mohan sir. Good evening, one to all present here, and I will give thanks to Lalit Mohan sir as well as Hemant Malhotra sir. They always force us to participate in such a great academic events, and they are, although 10 to 20 years elder than us, but they are more energetic and they are more active than all of younger as well as middle is like us, and I will salute Lalit Mohan sir for this great activity.
Thank you so much, Surinder, for your kind words, and we are always thankful to you that you are able to take time out of your busy schedule, and we learn from each other. Thank you so much. Please go ahead.
You are also busy like us, sir, but you will. So, okay, today's I have 2 topic. First is the ASCEND phase 3 trial, 3-year follow. In this, we will discuss acalabrutinib versus idelalisib plus rituximab or bendamustine plus rituximab in relapsed and refractory CLL. And probably this is the first trial in which they will compare BTK inhibitors versus PI3K inhibitor in CLL patients. And we all know that the preferred regime for relapsed and refractory CLL included either BTK inhibitor therapy or along or with the venetoclax, or sometimes we use bendamustine plus rituximab or ID or R. And acalabrutinib is a next generation covalent BTK inhibitor, and it is indicated by FDA for the treatment of adults with the CLL. And in primary analysis of phase 3 ASCEND trial, acalabrutinib significantly improves progression-free survival, which favors safety profile versus this standard treatment in patients with relapsed refractory CLL. And current study reports 3-year follow-up from this study. And we will first discuss the study design. This is a global, multicentric, randomized, open-label phase 3 trial. And in this, they took adult patients with relapsed refractory CLL as per International Working CLL criteria with 1 or more prior systemic therapy for the CLL, but no prior BCL2 inhibitors or any other BCL receptor inhibitor therapy. And there is no CNS lymphoma or leukemia, and there is no significant cardiovascular disease with the performance status less than 2. And they divide in 2 arms. First arm is the study arm. In this, they give acalabrutinib in 100 mg BD dose in 155 patients. And second arm is they have standard arm. In this, they have 2 type of treatment protocol. One is the idelalisib with rituximab, and another one is the bendamustine plus rituximab. And which type of treatment was used was physician's choice. And in this, approximately 119 will choose adalimumab plus rituximab, while the remaining will choose bendamustine plus rituximab. And the primary endpoint was the progression-free survival, and secondary endpoint was the overall response rate and the overall survival and safety. And the important point here is that the crossover permitted after confirmed progression disease. That's why the overall survival is not important in this study. This is the patient profile. We will not discuss about this. Approximately similar patient profile for each arm. And here the results after 3-year update, investigator assessed progression survival was better for treatment arm. In this 63% progression-free survival after 3 years, while in standard arm or physician's choice arm, only 21% progression-free survival. And if we will divide this in further, then in adolescent arm, 25% progression-free survival, while in BRM arm, only 9% progression-free survival. While the median progression-free survival was not reached in equilibrium arm, while 16.8% in physician's choice arm, while in adolescent 16.2% and in BR group 18.6%. And update based upon patient's risk factor, and in this also shows that this drug was effective both in high risk as well as in the low risk patient. And patients with deletion 17p, 66% progression-free survival in equilibrium arm, while 62% without 17p deletion, while in physician's choice arm only 5% progression-free survival in physician's choice arm, while 24% survival in without 17p deletion. And approximately same results were found in IG heavy chain variations. And if we study according to pre-specified patient subgroup, then we will see that approximately all groups either divided by risk factors such as deletion 17p, or by performance status, or by age, by sex, or by staging, or by either bulky disease or not. Approximately all groups favors equilibrium in spite of adalimumab or the bendamustine arm. And update of overall survival. Overall survival was 80% after 3 years in equilibrium arm, while 73% in adalimumab. And point to be noted that approximately half of the patients of the standard arm will goes over to equilibrium after the progression of disease. That's why overall survival is not important. And this was the update of according to industry assessment overall survival rate. Overall survival rate with lymphocytosis was 92% in equilibrium arm, while 88% in adalimumab and bendamustine arm. And now we will discuss about adverse events. Equilibrium has less adverse event than the ibrutinib in this study. Approximately serious events was 38% in equilibrium arm, while 63 and 26% in the study arms adalimumab or ibrutinib. And dose reduction was needed only in 5% in treatment arm, while in 13 and 14% in standard arm. And most common side effect was observed in this study is headache in approximately 23% of any grade, but more than grade 3 is only 1%. Second one is the neutropenia and diarrhea. And if we will discuss about class specific side effect, then the atrial fibrillation as well as the CNS hemorrhage and hypertension, both are approximately 7 to 30% in equilibrium arm, but the grade 3 or more are very less than 5%. This is a very important point. We will know that approximately 17 to 20% adverse events are found in ibrutinib, but the equilibrium has very less atrial fibrillation and flutter as well as hemorrhage and hypertension. That's why safety profile is also very good for equilibrium in spite of standard arm. So, according to investigators, they conclude that in patients with relapsed refractory CLL, prolonged progression-free survival with equilibrium versus standard of care regime maintained after 3-year follow-up, regardless of high-risk features. And hazard ratio for equilibrium versus the standard of care 0.29 with a very highly significant p-value less 0.0001. And the median overall survival not reached in either arm, and overall response rate comparable across the arms. Fewer toxicity-driven AE with the equilibrium while than the standard of care arm. That's why the equilibrium generally well tolerated with no new safety signals. The investigators conclude these data supports use of Daclotinib in the relapsed and refractory CLL. And my next. My next topic is phase 3 SPELIA arm in trial in this Zanubrutinib versus the bendamustine and rituximab in previously untreated CLL patients. BTK inhibitors, ibrutinib and the eczotinib was preferred first-line treatment for the CLL or small cell lymphoma. And zanubrutinib is a selective second-line generation BTK inhibitor. In phase 3rd Alpine trial, zanubrutinib demonstrates improved progression-free survival and a lower rate of atrial fibrillation compared to ibrutinib in relapsed refractory CLL. And the present trial is investigating zanubrutinib alone or in combination with venetoclax in multiple cohorts of patients with the previously untreated CLL patients. In the cohort patients with the deletion 17p, zanubrutinib monotherapy was active. And current interim analysis reports the efficacy and safety of zanubrutinib versus BR. The study design, this is a multicentric, multi-cohort, open-label, part randomized phase 3 trial. In this, they took untreated CLL patients who meet IWCLL criteria for treatment with the age of 65 or more or unsuitable for FCR treatment with anticoagulant or inhibitor permitted. And the primary endpoint was independent review committee assessed progression-free survival, while the secondary endpoint was investigator assessed PFS, oral survival, OS, and safety. In this, there was 3 cohorts. In the first cohort, without deletion 17q by the central phase, and they divide in 2 parts. First is they give single agent zanubrutinib 600 mg BD until progression of disease or intolerable toxicity or the end of the study, while in another arm they give bendamustine with rituximab. While in the cohort second, which was with the deletion 17, and they give there is no comparable arm in this cohort 2, and these patients received zanubrutinib monotherapy. In the cohort 3, patients received zanubrutinib with venetoclax treatment allocation without randomization. These are the baseline patient characteristics, which are approximately similar for both arms. And according to results in independent review committee assessed progression-free survival in cohort 1, in zanubrutinib, there are approximately 85.5% after 24-month progression-free survival, while in BR 69.5% with significant p-value. Hazard ratio is 0.42. It means very good response. And this table shows that approximately all patients favors to single agent zanubrutinib, while the BR, if we compare with either age, male, sex, or performance status, or various type of risk stratification. And in this, they assess by IGV status. In this, they also found that the zanubrutinib has a better progression-free survival than BR. And in OR, approximately similar results with BR and zanubrutinib. And in adverse events, they found that the grade 3 adverse events was 52.5% in a single agent zanubrutinib, while in BR, there are approximately 79.7% of grade 3 ERs. And AEs which are leading to dose reduction needed is also fewer in the zanubrutinib arm than the BR arm, only 7.5% versus 37.4%. And the dose interruption needed is also fewer than in standard arm. And these are some common side effects. So the contusion is the most common side effect found in the arm, with the upper respiratory tract infection and as well as diarrhea. These are the common side effects, but all these side effects are manageable. Grade 3 or more side effects are very less, except neutropenia. And this graph shows in cohort 2 with patients with the deletion 17p, means high risk patient with only zanubrutinib arm. In this, they found that there is very good response even after 3 years. So, investigators' conclusion of this trial is that in the patients with untreated CLL, IRC assessed progression-free survival was significantly improved with zanubrutinib compared to BR. 24-month progression-free survival was approximately 85% in treatment arm versus the standard arm 69.5% with hazard ratio 0.42. Progression-free survival also was superior with zanubrutinib across the high-risk subgroup, including patients with unmutated IgSV and the deletion 11q. And zanubrutinib was well tolerated and no new safety signals were observed, and atrial fibrillation and flutter was also infrequent. And investigators conclude that the zanubrutinib is a safe and effective treatment for patients with previously untreated CLL patients. Thank you. Thank you very much.
So thank you so much, Dr. Surinder, for great inputs and explaining all the two studies at length. Next is the panel discussion on leukemia. And first foremost thing, Dr. Vishnu Sharma has agreed to conduct this panel discussion. I am thankful to Dr. Vishnu Sharma. He is budding hematologist in Rajasthan. He is working as assistant professor in SMS Medical College Hospital in Jaipur. And the panelists are, I request everyone to participate in this particular panel. Dr. Sandeep Berwa is from All India Institute, Jodhpur. Dr. Sandeep, welcome and thank you so much for joining. Dr. Naresh Somani has left. In fact, he was busy with something else. Dr. Ankit, Dr. Rohit, and Dr. Surinder has already been introduced. So I'm requesting everyone else also to contribute to this. And by doing this activity, I'm very sure that we have now become Atmanirbhar sort of thing, that in Rajasthan only we have good number of hematologists, medical oncologists. So we should do more and more activities with our local colleagues rather than inviting outsiders. With this small word, over to you, Dr. Vishnu, for your panel.
Thank you, sir, for your kind introduction, sir. And thank you, organizing committee, for giving me this opportunity. So, panelist has already been introduced by Lalit, sir. May I share my slides, sir?
Yes, please. Please go ahead.
Sir, any issue that you're facing in sharing your slides?
Just wait 1 minute. Wait 1 second. Actually, I am taking first time from Keynote, this MacBook.
Sure, sir. So I can just guide you with the steps, sir. So if so, just wanted to confirm, sir, is your presentation slide?
Not visible, no?
This meeting is being recorded.
So you can just say next whenever you want us to go to the next slide.
So it is being shared from your side?
Yes, sir. So we have shared the slides from our end. So you can say next whenever you want us to go to the next slide.
So actually, the slide which was mailed by me was different.
Sure, sir. So would you like to try sharing it once again, sir?
Of this presentation.
So if you could try sharing it once again, sir, if you can click on share screen.
Sir, my patients are doing well, sir. Till now, they are in the BCR-ABL counts are continuously decreasing. The patients has brought the 3 months BCR-ABL less than 10%. So it's working for me.
Okay. How about Dr. Rohit? In fact, I am not yet confident. I tried in 2-3 patients, but then in some international platforms I discussed, and it was made to us very clear that in CML, 100 milligram is the dose, and the studies which say 50 milligram, there is no robust data. So in fact, I'm not yet confident, but I'm tempted to use 50 milligram if possible. Dr. Rohit, your thoughts on that?
I stick to the 100, but if the patient does not tolerate, then we start tapering off. But as a standard, I start with 100 itself. Although the MD Anderson data is reasonably convincing, it's just retrospective in nature. So.
Very true. In fact, whether to start with 100, if the patient goes sort of with significant side effect, we reduce to 50, 70, then 50, versus other strategies that you start with 50 and then you build up. So I think 100 milligram OD is still the most commonly used. In time, we may get the 50 milligram dosing schedule also. Dr. Upinder, any thoughts? Dr. Deepak Shukla?
Yes, sir. I am actually using 100 only to begin with. No? Only if patient is not tolerating, then only I switch to 50, means as 70, then 50.
How about Upinder, your thoughts on 50 milligram?
Sir, this is only a single paper. They've used high-risk patients were there. So, sorry, low-risk patient were there. So, for most of a patient, I use 100 milligram. If patient is not tolerating, then I switch to low dose of dasatinib. For each and every patient who is tolerating full dose 100 milligram, my preference is to go with the 100 milligram.
I think that is very important that in this study which has been discussed, in fact, the patients have been of low pulse score. And in our clinical setting, we see patients who are high risk, young patient, and to me it appears that we get only one chance. In fact, the second time or when the patient progresses on one particular TKI, it becomes difficult.
And so in this paper, also today's presentation, those patients who are high risk, they were preferably should be excluded from this.
Very right.
They were excluded. Yes. So high risk, yes, definitely. For low risk, we can think of either 50 milligram or 100 milligram. But for those patients also for low risk, if you are starting upfront with dasatinib and a young patient, so our goal is treatment-free remission for those patients. And for those patients, so if we initially we monitor very frequently, every 15 days, CBC. If patient not developing cytopenias with the full dose of dasatinib, continue with the same dose of dasatinib. They are having cytopenias, then do with 70 or 50 milligram. So, or these patients, once they have a deep molecular response, early molecular response at achieving their milestones on time, then they can be a good candidate for in future having option for TFR.
Dr. Vishnu, any updates on the presentation?
So, sir, it's not working, sir.
So you can start, in fact, without that. We all sort of have heard the presentations. Yes. So you can continue, in fact.
So as the ASCEMBL trial, which was discussed by Dr. Ankit. So Dr. Ankit, how confident you are that the asciminib will be upfront drug in the future?
Okay. Am I audible?
Yeah, you're audible.
Right. So I think the 48-week data that has come up is quite significant. The major molecular response that has shown has been quite significant. Asciminib versus bosutinib, and there have been trials that are ongoing for first-line treatment with asciminib. So looking at the data, it has already already been compared with bosutinib, and it is showing a good major molecular response at 48 weeks. It's a good drug that has a very good potential to be used in the first line once we have the data.
So in this trial, basically more than 3/4 patients who are on bosutinib were changed, either because of side effect or because of inadequate response, or they are switched to this asciminib. So how?
Dr. Vishnu, can I comment to that? In fact, if you see the asciminib trial, I felt there are two issues. One is they have chosen the comparator arm as bosutinib. I think the ponatinib is much stronger arm. So the ponatinib would have been a better or equal comparator as compared to bosutinib. And second thing, most patients, those were included, they were sort of not resistant. In fact, they were intolerant to the TKI. So
Yes.
these are two important points which I felt are of significance, but it seems to be a good trial. Yeah, please go ahead.
So patients were on who has received 2 or more than 2 TKI, who were T315I negative. These patients were included. So patients who had intolerant to other TKI had found to have better response with asciminib compared to those who had resistance. So this is one important message from this trial.
Exactly. Absolutely.
Coming to the second trial, that is this low dose decitabine trial. So in this trial, the low dose decitabine 50 milligram was compared with 100 milligram. And we have, at least I have used in few patients who developed myelosuppression with 100 milligram of dasatinib, and they are doing good with dasatinib of 70 milligram. So I haven't used 50 milligram in these patients, but 70 milligram, these patients are doing well. In fact, one patient who developed severe myelosuppression, grade 3 myelosuppression, platelet count was less than 25,000, and ANC was less than 500, was switched to 50 milligram, 70 milligram dasatinib, and she has attained major molecular response at 6 months only. And her BCR-ABL is undetectable at the 12 months time point. So I think there are sufficient data to suggest that 50 milligram or at least 70 milligram is as effective as 100 milligram dasatinib, and it has been substantiated in other trials also. So what is your opinion, Lalit sir, on this topic?
Still, in fact, I am not fully confident, because I feel that CML is a highly curable disease, and the ultimate goal in most patients where we use the second generation TKI, the goal of treatment is TFR in fact. So I feel that why take a risk in this highly curable cancer at this point? So yet I am not confident, and the number of patients included in the 50 milligram study are not that high number to convince. So yet I am not able to generate that confidence of offering 50 milligram to my patients.
So, Dr. Upendra, can we use this ELTS score or SOCAL score to choose the dasatinib dose, like 70 milligram, 50 milligram, or 100 milligram, based on low risk, intermediate risk, or high risk, especially in patients in whom we are targeting treatment-free remission?
So, Dr. Vishnu, for those patients who are we are targeting a treatment-free remission, either they are a high risk or low risk, irrespective, we should go for the full dose of dasatinib 100 milligram. For only so some subset of patient wherein they are low risk, we can opt for a 50 milligram. But when our target is a treatment-free remission, so first we have to see if patient is tolerating the full dose of dasatinib, we should, with respect to the risk score, we should go for full dose of dasatinib if our goal is treatment-free remission.
Okay, thank you. Actually, one study published in American Journal of Cancer Research, in which they included almost 300 patients, around equal patients in both 50 milligram and 50 milligram arm, and they compared with this dasatinib trial, the historical trial, and they found that 50 milligram is even better than 100 milligram, and the response rates are even better with 100 milligram, and same with tolerability.
So the response rates are better because adherence with 50 milligram is good. Most of these patients, they tolerate 50 milligram very well. Interruptions and discontinuation with the drug is very less. With the 100 milligram, most of the time, most important side effect is myelosuppression. And majority of these patients, they have treatment interruption because of myelosuppression.
Yes.
So with one or two interruptions, we usually switch to a lower dose with 50 milligram. For those patients, if they are not having the challenge of myelosuppression, we continue with the 100 milligram. So we can wait for one or two instances wherein we have to decrease the dose. Yes, if we have to decrease the dose, then go with the low dose, and else we can continue with the full dose of dasatinib.
Okay. So standard of care is still 100
Sorry to
milligram.
interrupt, Dr. Vishnu. So we have played your slides from our end, sir. So you can say next whenever you want to go to the next slide.
Next slide, please. Next slide. Next slide. This next dasatinib trial. Next slide. So, this agile trial. So in this trial, previous slide. First slide. So in this trial, IDH1 inhibitor ivosidenib was combined with azacitidine or azacitidine alone. But still, ivosidenib alone is indicated in elderly patients with IDH1 mutated disease, or in patients who are less refractory with IDH1 mutation. Even single agent ivosidenib can be used. So, what is your opinion with ivosidenib with azacitidine versus azacitidine, or ivosidenib as a single agent? Dr. Verma. Dr. Sandeep.
Sir, the combination has increased response rate and increased survival. I have not used. I'm not having much insight about this. Maybe the other panelists can answer better than this question.
Okay. Dr. Upendra?
Yes, I think we have not used this yet, but seeing this trial, this combination of ivosidenib with azacitidine, interestingly, if we add any sort of, we combine a drug with a pre-existing drug, most of the time we see that patient is having side effects with the combination. But interestingly, in this trial, we have seen that combination of ivosidenib and azacitidine has lesser side effect as compared to those patients with placebo and azacitidine, and they are having good event-free survival rate with the combination as compared to the placebo with azacitidine.
I also agree to this, Dr. Vishnu, that the drug sounds safe and it has got a specific inhibitory action against IDH1. So the combination, in fact, these all are elderly person. So our aim is only to control the disease in best possible way.
And so, better event-free survival is our goal. Because oral survival, most of these patients, they don't have good oral survival. But event-free survival, if you can offer to a patient, then yes, we have done with our job.
And this is probably because of early hematopoietic recovery with azacitidine plus ivosidenib.
With the combination, yes, with lesser side effects. Interestingly, it was a very catchy point that combination is having lesser side effects as compared to the placebo with azacitidine.
Yes.
Dr. Vishnu, you can ask Himanshi to keep the slides moving.
Yes. Next slide, please. The conclusion slide. Next. Yes. See, the overall survival and clinical response was better with azacitidine plus ivosidenib, and the adverse effects were almost similar. Next. So in this trial, the gilteritinib with azacitidine was used. So the overall survival with gilteritinib with azacitidine versus the azacitidine alone is almost similar. There is no significant difference, or the p-value was not significant with combination therapy compared to the single agent therapy. So what is your opinion, Dr. Rohit, on this study, outcomes of this study?
I think what it basically tells us is whether you use it in the beginning or you use it later on, it really doesn't make a big difference in overall survival. It definitely gives you some amount of EFS benefit. But, like we saw in the Admiral trial, that there was a significant CR difference. We did not actually, in the relapse setting, we did not actually see that in this particular situation. So either we use it first or you use it later on, because quite a few of these patients actually later on went on gilteritinib, the patients who were on the azacitidine group, or they went on other molecules, sorafenib or quizartinib also. So whether you use it first or use it later, I think doesn't really matter. I think that is the basic, thing that this study is actually telling us.
So I think overall survival with combination was around 4 months. With single agent is around 2 months. So there is no major difference between overall survival, and PFS is also almost similar. There is no difference, significant p-value difference with PFS also.
Yes, there's no difference in the p-value. But if you look at the numerical value, it looks more. But the p-value, there is no difference in the EFS also. OS is the same in both the arms.
And is this molecule available in India? Anybody has used the gilteritinib?
I have personally not.
Okay, so I think we have now generic midostaurin, so we can combine midostaurin with azacitidine instead of this costly molecule without getting much PFS and OS benefit. Lalit sir, what is your
no, I think this is second generation. In fact, midostaurin in the Western world has become first gen. So this is much stronger. Like we can see the people sitting in the panel also, first generation, second generation, third generation. So third generation is usually much more vibrant, energetic, and full of energy. So same thing applies here also, probably that this is the second generation. So the expectations are much higher. And of course, we don't know, in fact, and these all are new molecules. So maybe that in future, we may come to know their better uses. But at this point, no, in fact.
Next slide, next. Conclusion slide, please. Previous slide, previous conclusion slide of this previous.
Yeah, so this is conclusion slide. Next, please. This is conclusion slide.
So the median OS was 9.82 versus 5.87. There is no significant difference. P-value was also not significantly different. The CR is slightly significantly higher, but overall survival is almost similar. Hardly 3 months, 4 months difference in the OS, and PFS also no significant difference. Next slide, please. So in this trial, the second generation or third generation BTK inhibitor was compared with bendamustine and rituximab, and it has shown significant difference in the overall response rate with the acceptable side effect profile, except some the arrhythmias and bleeding tendencies. The response rates are better, and this drug is even better in patients with TP53 mutation or deletion 17p. So what do you think, sir, utility of this molecule in the coming future? Dr. Sandeep.
Sir, as of now, the availability is an issue. So we have availability ibrutinib and acalabrutinib.
Yes.
For the TP53 subset, it's a very good choice.
Dr. Sandeep Vishnu is asking about if you consider that everything is available. We are discussing science.
In the near future, in the coming future.
Yes.
For TP53 subset, definitely zanubrutinib is the best choice.
Very right.
I think the PFS OS benefits were reported with zanubrutinib, but there is no head-to-head comparison between these BTK inhibitors between ibrutinib, acalabrutinib, and zanubrutinib. So I think all BTK, especially the response rates with acalabrutinib and ibrutinib, are almost similar, except some difference in the side effect profile. So we have ibrutinib available with us, and everybody is using ibrutinib and getting good results with ibrutinib, even in patients with TP53 mutation. So I don't think, or I think whatever difference in the survival we may get in the future is still a question. So Dr. Upender, what do you think about the utility of this molecule in the near future?
So if you can see this trial, Zanubrutinib has done better with when it was compared with bendamustine. So there was a better event-free survival, progression-free survival, but there was no overall survival benefit with this drug. Yes, lesser side effect with lesser bleeding symptoms, lesser atrial fibrillation with zanubrutinib. So yes, BTK inhibitor, with this BTK inhibitor, we can see a good feature in a patient of CLL, just like ibrutinib, acalabrutinib. Just we can, Dr. Vishnu, just like in CML, we have not had head-to-head comparison with dasatinib, nilotinib, other of these drugs. So most of these, they are compared with first generation imatinib. Just like in these BTK inhibitors, there is no head-to-head comparison. But when we have a better second or third generation of a BTK inhibitor, they are having a targeted effect, lesser side effects, lesser what the incidences we see with the atrial fibrillation, bleeding manifestations with ibrutinib. They are said lesser with acalabrutinib and zanubrutinib. So with more refined drugs, lesser side effects and better tolerability and good results we are seeing with these BTK inhibitors.
Thank you. Dr. Beniwal, Dr. Surendra Beniwal. So basically the
Surendra has in fact left. He had some urgent work, so he has left.
Okay, so the BTK inhibitors are definitely better in terms of PFS with bendamustine rituximab and even with FCR. If we talk about TP53 mutated and IGBH unmutated patients, so this will be I think future in the treatment of CLL, not only in TP53 mutated patients but in elderly TP53 negative patients also do better with these BTK inhibitors. So with this, I end my presentation. Thank you, sir. Thank you for giving me this opportunity.
So thank you so much, Dr. Vishnu, and I thank all the panelists and all the faculty present here, Dr. Ashish Verma, Dr. Deepak Shukla, Dr. Annu, Dr. Ajay Yadav, Dr. Ankit, Dr. Rohit, Dr. Upendra, Dr. Ajay Yadav, and Dr. Surendra Beniwal, Dr. Hemant Malhotra, sir. And at the end, I convey my sincere thanks to the CIPLA team for excellent opportunity to all of us. And this time we have proven that, yes, the team from Rajasthan can also do better than anybody else. And over to the CIPLA team, Dr. Devang or Varinder Singh ji for any input from your side. Thank you so much. Truly enjoyed the 2.5 hours discussion.
I would now like to invite Virendra sir to give the closing remarks.
Hi, good evening, sir. I think it was wonderful, like always, sir, to be part of meeting organized by you, and we are really privileged that you have given honor to us to be part of this meeting. And I really thank all the faculties for putting across beautiful presentations and a wonderful discussion. And with that, sir, I'd like to say thank you. I'm looking forward for these kind of meetings again. Might be in other topics, sir. As a CIPLA oncology team, we will be there for any of the scientific programs, sir. And thank you and good night, sir. Night to you.
Thank you so much. And at the end, thanks to Kavina Creations, Kashish, Himanshi, and Sophia for excellent management of the time and slides. Thank you so much. And with this, we wind up. Good night, everyone. Shubhratri. Take care. Have a good weekend. Bye-bye. Take care. Thank you.
Thank you, sir.
Thank you so much, sir. Thank you.
See you,
Thank you, sir. Good night, sir.
Lalit sir, with your permission, I may end the meeting.
Sir has logged off.
Yes. Thank you.
Thank you, everyone.